Good morning and welcome to the session on the submerged iceberg. This is the session for, in the pandemic, not only those people who have been infected with the virus, but those who have been affected by the deliberate, the unintended consequences, if you like, of deliberate actions, the so-called indirect effects on health. And many groups around the world were on this question right from the early days and weeks, stimulated in part because early observations showed that the severe infection affected people with underlying conditions, a profoundly important problem, particularly as many countries around the world face growing problems with multiple conditions, multimorbidity. I'm delighted to welcome our three speakers this morning who are going to give different and complementary insights on the indirect effects of the pandemic. I'm going to start with Richard Wood, who's the head of modelling and analytics in the Bristol Clinical Care Commissioning Group and is the associate director of the Southwest Health Data Research UK. Richard.
Thank you very much, Harry, and good morning, everyone. I hope you can hear me okay, and I think slides are just loading up now. Fantastic. Right, so yeah, good morning, everyone. So I'll get straight into it, so we've only got a few minutes. Could I get the next slide, please? Thank you. So first of all, there's clearly a huge amount of very high quality applied research that has massively influenced and improved patient outcomes and healthcare management. And no doubt some of this has helped to embed analytics within routine use on the ground in the NHS and indeed other healthcare systems. But there's still, at least in my opinion, a long way to go before we can fully ingrain data analytics into day-to-day decision-making within the NHS. And while I refer to the UK's NHS, National Health Service here, I think this is not exclusive to just us. There's affects other healthcare systems around the world as well. Next slide, please. Fantastic, that's it, thank you. So in the Bristol NHS healthcare system, we cater for about 1 million population. We've had, in order to try and address this issue, set up a dedicated modelling and analytics function, and that's been live for well, exactly 3 years now. And the ambition of that has been to try and ingrain some of the data and analytics into day-to-day decision making. So in this talk, I'm going to give an overview of some of our efforts in responding to the COVID-19 pandemic, which has helped to embed as a catalyst, really, our routine use of analytics in the healthcare system. Next slide, please. So the analytical support we've offered and provided to the system has evolved in response to the pressures and priorities of over the course of the pandemic. This has covered direct impacts of COVID-19, such as immediate pressures on ICU, which was our first undertaking and modelling those, and understanding the impact of vaccination on admissions, which we looked at using epidemiological modelling, and looking at triage policies as well for intensive care. But we've also been looking at indirect impacts of COVID-19, and that's what I'm going to talk about today for a few examples. Next slide, please. Thank you. So going kind of in chronological order then, so one of the first kind of involvements we had in response to the indirect effects of the pandemic was quite early on. We knew, for background, for context, there was a decision made to postpone for at least 3 months all non-urgent elective treatments from mid-April 2020. Obviously, this is going to affect waiting times for elective treatments. The question is, how much will these be affected? So we used discrete time simulation using a link data for waiting list data, referrals, and capacity information, including projections under various scenarios that were considered plausible early on in the pandemic when much was still unknown. And we used simulation to then project forward the effect of these capacity restrictions into the future. And what we have here is a graph of the principal measure for elective performance in the UK's NHS, which is referral to treatment, which measures at any point in time the percentage of unresolved referrals that are waiting under 18 weeks. And the target is that it should be at least 92%. So you can see here the reductions all the way down to 60% and so on that were projected, and which were actually we got down to some of those numbers as well. So the outcomes of this, then, why this mattered, it helped us understand which specialties and hospitals are most affected within our patch from these elective capacity restrictions, and indeed where capacity reallocation should be focused, i.e. to those specialties that will be most affected. Next slide, please. Thanks. So in the UK, we early on, a decision was made to shield parts of the population that were considered extremely vulnerable to COVID infection. These were people who were asked to stay at home for a not insignificant period of time. These patients, also being vulnerable, are also have other health conditions which staying at home can exacerbate. So patients with heart issues, not having exercise is a problem. So the question for us was just to understand who are these people, who are our shielded population. So in our 1 million population, there's 30,000 people who were asked to shield. We linked data for all of those patients, and we performed a cluster analysis just to understand at a very high level who these patients were. So the results of that are provided in the table. We identified 6 segments, which we obtained differences in various different things. I've presented only some of those measures here. The key outcomes from this was we identified mismatches in primary care demand and capacity throughout our geographic area. Mental health teams were alerted to the high-risk mental health cohorts, and we were also able to tailor the design of public information on healthy shielding advice that we put out there from the CCG. Next slide, please. So sticking with mental health, actually, our attention turned in the summer of 2020 last year to this concerns around pent-up demand for mental health. Referrals have been very low in the months following the start of the pandemic, and the questions for decision makers and service managers were around what's going to happen if all of this is released into the system following the first wave. So we approached this problem using stochastic simulation, using basically queuing theoretic methods to model the whole of the mental health system, which is on the left-hand side there, and the flows of patients around that system in the dynamic modeling setup. And the results told us, basically, according to some different scenarios, what would be the effect of different interventions. There were 2 interventions we were considering at the time, in order to try and mitigate the effects of a surge in demand post first wave. And the outcomes of this modelling helped improve where we actually put some of our additional capacity for mental health services. And the model is now being used, actually re-updated to support recovery after our second, third wave now. Next slide, please. Okay, thank you. Throughout the summer, we'd rapidly made use of telehealth for outpatient treatments, and we were really interested in what has been the impact of mass telehealth use. We'd never used telehealth to this extent before in our system. So at our disposal, we had 3,000 patient surveys. Patients were surveyed following their outpatient virtual appointment, and data for a good number of outpatient activities. And as you'll see from the results on the right-hand side there, the question is not, can we roll out telehealth? We know we can. We can see there the yellow and the red are basically our physical outpatient attendances. The blue is the virtual attendances, and that's split by, I think, about 20 specialties there. So this shows the differences in how different specialties have used telehealth. So we know that they can rapidly deploy telehealth. That shows by some of the top lines there staying on course and just the shift between the physical and the virtual. The question is really, should we be? And we've approached this really for understanding, firstly, from a patient perspective, and what we can see there on the left, more patients preferred virtual than physical. However, interestingly, 17% of those who preferred virtual have said that they would prefer physical after the pandemic. So understanding that's going to be quite useful for us. But also we looked at not just patient preference, but try to infer clinical efficacy. So we looked at duplicative physical appointments and whether there was any, the extent of those following the virtual appointment, to try and work out whether the virtual appointment was not resolving the issue, and whether a physical appointment was thereafter necessary, and thus one is a duplication of the other. And we found little evidence of this, indicating that for some specialties, virtual appointments can be effective. Should just mention that this was for a particular cohort that were offered telehealth and that were considered to be more receptive to telehealth than perhaps some other types of patients. There is some potential for bias in that. Next slide, please. Okay, so finally then, just going to pick up on something we've been doing recently. The question here was, how will recovery, following the UK had a major second wave which peaked in mid-late January of this year, and since we've been in various stages of recovery with the vaccination effort. The question was, we know societal restrictions and relaxations to societal restrictions, which have been sequential in the UK, have affected COVID-19 emergency care and urgent care demand. The question was, though, what about non-COVID A&E demand, so ED demand? So, intuitively, as there are societal restrictions, you would expect that there would be less, for instance, sporting injuries and road traffic accidents and so on that would necessitate urgent care activity. So what we did here, we obtained Google's community mobility data for our patch, for our geographic area, and we looked at the weekly measures of that versus our weekly A&E attendances over the course of the pandemic, and found actually a very convincing link on the left-hand side there, just a simple ordinary regression. And what this enabled us to do then was to be able to phase in the sequential relaxations from that point of the analysis, which was around March this year, in order to play out what would happen to non-COVID emergency care, urgent care demand as we exit the restrictions. And we can see on the right, to the right of the red line on the graph, the effect of the different relaxations on non-COVID urgent care. And this has really helped service planning in our local area in terms of acute hospital planning, but also to inform community capacity procurement. But a not insignificant amount of acute admissions require downstream community care. So this has been useful in terms of understanding the need to procure additional capacity in that regard. Next slide, please. I think that then concludes my slide. So just to acknowledge the support of some key staff and collaborators for these works. Thank you very much for your time.
Richard, thank you very much for that, sharing those insights from use of predictive analytics in a local regional health system. Really terrific data. Thank you. And please, everybody, think up your questions, send them in. There'll be an opportunity for discussion at the end. So if we move forward to Professor Mark Lawler, who's Deputy Pro-Vice Chancellor at Queen's University Belfast, Chief Scientist at DataCan, which is the Innovation Hub for Cancer and Health Data Research UK. Mark.
All right, thank you very much. And thank you to Andrew for inviting me to speak at this session. Next slide, please. Really want to focus on two things here: the involvement of patients and team science. As Margaret said earlier on, it's important that patients are not just engaged, but are also actively involved. And we've made that really part of our working DataCan. Patients are really at the heart of everything that we do. You can see here at all levels of DataCan, steering board, management group, etc., and have been involved in the original writing of the grant, reviewing projects, contracts, co-author publications, etc. And I love this quote here from Jackie Gath, who's one of the patient advocates who we work closely with in this regard. Next slide, please. What I want to do really is to share with you a story that's emerged over the last, next slide, please, that's emerged over the last 15 months. And for me, actually, it was started off as a personal thing. My uncle died of a COVID-related illness on the 29th of March 2020. And Edward Vidoliak is a colleague of mine from Croatia, an oncologist, while reaching out to me to sympathize with me on my loss, also said this really chilling phrase: people are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. That really worried me, because anecdotally we'd heard similar reports in the UK, but no real evidence. Serendipitously, Harry himself also reached out to me actually the same weekend and said, wouldn't it be interesting to do a data-driven collaboration between DataCan and University College London, so between a HDR UK hub and a HDR UK substantive site, and really look to see, can we put some meat on the bones of this to actually say, is this statement true or not? And so two things we did: looked at real-time data from hospital trusts across the UK, and then with Harry and Alvina, you see there, model excess deaths due to the potential adverse impacts of the pandemic. Next slide, please. So we immediately set to work on this project, because it was obviously very critical that we get these results quickly. Next slide, please. And these just summarize just some of the work that we found. So just first of all, focusing on real-time data, we can see here, looked at 2-week waiting time for cancer referrals, really that early warning system, and found that 7 out of 10 people with suspicion of cancers were not getting referred to cancer specialist services at the appropriate time. And similarly, looking at the treatment pathway, chemotherapy attendance, 4 out of 10 cancer patients not getting access to their chemotherapy. The modeling studies that Harry and Alvina did showed that between 7,000 and 18,000 excess deaths. So this was the first data really in the UK that drew the attention of governments, academia, the NHS and the public to the potential disastrous impact of COVID on cancer services, and particularly on cancer patients. Next slide, please. We then moved on to actually look in more detail at what was happening in relation to this. Can I have the next slide, please? And what we found was really that the disruption was held across the entire cancer pathway. So presentational delay, diagnostic delay, and also significant impact on treatment. Next slide, please. We also saw that there was significant impact on cancer research in relation to clinical trials, and dropping in some stage to 20% of normal activity, and also translational research. Next slide, please. And we also then looked to see what would be the impact on 5-year anticipated survival. And you can see here for lung, for breast, and for colorectal, you see significant impact. In fact, for colorectal, we may be setting back the progress that we've made over the last 20 years, nearly a decade, in relation to 5-year anticipated survival rates. Next slide, please. And so really that 1 step forwards, 2 step backwards approach. Next slide. Next slide, please. We also looked down on the impact on cancer services, and this is work done with Lawrence Lovett and Alex Ho in UCL, and you can see there, significant drop down to nearly 10% of the level in relation to endoscopies. And so again, showing a significant impact that we're seeing in relation to cancer services. Next slide, please. We then, as you know, COVID, just like cancer, doesn't respect borders. So we presented our data both to the European Cancer Organization and also to WHO Europe. The European Cancer Organization immediately decided that they needed to set up a special network on COVID-19, which I'm privileged to co-lead with Miriam Krul, who's a pharmacist in Amsterdam in the Netherlands. And what this led to was bringing together rapidly experts from across Europe. And what we did was we developed a 7-point plan, which we launched at the European Cancer Organization Summit on the 18th of November, 2020. Next slide, please. If we look at this 7-point plan, it highlights the urgency of actually reducing that cancer backlog, but most importantly, restoring confidence of both citizens and patients in cancer health services. Also, we see tackling both shortages in relation to medicines, workforce gaps, ways in which we can strengthen cancer systems, and also looking at that rapid deployment of cancer intelligence, really important. So really all of these approaches to make sure that cancer doesn't become the forgotten sea in the fight against COVID. Next slide, please. We were then approached by a number of people following the summit asking us, would we actually run a campaign on the impact of COVID, so a public campaign. We discussed this with the board of the European Cancer Organization and developed a Time to Act program. And this has two parts to it, a data intelligence study across Europe to look for evidence-based messages, and then looking at the campaign itself, which was translated into 30 languages across Europe. Next slide, please. And again, emphasizing that cancer must be at the top of the agenda. We can see here just some of these numbers are really worrying, as you can see, in terms of numbers of cancer screening, maybe 1 million cancer patients who are walking around currently undiagnosed due to the impact of COVID. Next slide, please. You also see the impact in relation to cancer patients. Next slide, please. And also cancer professionals. So you can see here the impact on treatment, particularly on surgery and chemotherapy. You can see this worry in cancer patients in relation to attending for cancer treatment, or also citizens in relation to attending screening appointments. And you can see there on the cancer workforce, 4 out of 10 with burnout, 3 out of 10 with signs of clinical depression. Next slide, please. And so this is the Time to Act campaign. You can see it also behind me here on the screen. 3 key messages for cancer patients and citizens: don't delay. So if you have warning signs, lump on your breast, bleeding from your poo or pee, if you have difficulty swallowing or are seeing unusual weight loss, really go to your doctor, and also keep your screening and treatment services. Cancer services are safe. This is really the key message we want to get across. For health professionals, really, you're not alone. You can be supported by professional organizations, and also look at ways in which we can share best practice. But most importantly, for governments, for policy leaders, and for health system leaders, getting cancer services back on track has to be at the top of the agenda. I'm being very blunt about this, but this is really important. Every action we do now to address the cancer backlog can help save lives. So Time to Act is very much the principle that we should work by. Next slide, please. And already we've, as well as having the European launch, which we first presented this data to the European Beating Cancer Committee on the 10th of May. The official European launch was on the 11th of May with Stella Kyriakides, who's the European Commissioner for Health and Food Safety. We've also had national launches in Poland, in Italy, and in Spain this coming Friday. And we obviously would like to have a launch in the UK, and certainly work with HDR UK to do that. You can see the different countries that are interested in doing launches. Also, this work we were privileged to receive just recently this month, the Royal College of Physicians Excellent in Patient Care Award. And really, this is a patient-centered initiative. Patients have been involved from the very start of this initiative, and you can see now not only having UK relevance, but also very much pan-European relevance as well. Next slide, please. So Time to Act. The time to act is now.
Mark, thank you for that rousing tour through these really important data and insights in cancer. So from cancer to mental health, I'm delighted to welcome Dr. Rashmi Patel, who is an HDR UK, UKRI funded fellow, who's going to tell us about the experience in South London, the Maudsley Trust. Rashmi.
Great, thank you very much. And can you see my slides?
Yes.
Great, okay. So I am an MRC Health Data Research UK Fellow at the Institute of Psychiatry at King's College London, and I specialise in electronic health record data analytics. And I'll be presenting some data on the impact of the COVID-19 pandemic on remote mental health care. So the data I'm presenting are from the South London and Maudsley NHS Trust, or SLAM, which is a large provider of secondary mental health care. The trust provides community and inpatient care to around 37,500 patients per week. And as part of the NIHR Maudsley Biomedical Research Centre, we have access to an electronic case register of de-identified EHR data from SLAM. And going back to 2007, we have almost 500,000 patients' data, including both structured fields and the unstructured free text, which the clinicians document as part of routine clinical care. During the first wave of the pandemic, there was a call to identify how we could analyze the de-identified EHR dataset to understand the impact on mental health care, and in particular, the rapid shift to remote mental health care, which was unplanned and came about due to the lockdown and travel restrictions. So I extracted some data and analyzed it using a data visualization tool called Exploratory. So this chart illustrates the number of mental health service contacts in a given week, broken down by whether they were in person in blue here, remote care in orange, and then unattended appointments in green here at the bottom. And you can see at the end of March and beginning of April, there was a substantial reduction in in-person contacts and a marked rise in remote contacts as the first lockdown began. And we can see this pattern persists even up to the beginning of September, during a period when the lockdown restrictions were eased over the summer. On the other hand, looking at data on psychiatric medications, although there seems to be a gradual increase in mentions over time, this is data for antipsychotics, there doesn't appear to be any clear change associated with the onset of the pandemic, which suggests that activities like medication reviews, initiating new medications, it was possible to do this during the lockdown period. However, if you break down contacts by age group, you can see that the shift to remote mental health care is greatest amongst children and adolescents, with a moderate shift in working age adults, but much less of a shift in older adults, and perhaps indicating potential barriers in accessing remote care for this age group. Another striking finding is the marked rise in the use of video consultations. Prior to the pandemic, hardly any remote consultations occurred over video. You can see, just around 10 or 20 per month, these figures are. But now they account for almost a third of remote contacts. And this has very important implications for mental health care in particular, as there are several possible benefits, such as the ability to see people on screen, as well as the environment that they're in. Now, I want to talk briefly about how this approach could be taken further and how electronic health record data could be harnessed to actually inform the care that patients receive. And this slide illustrates an initiative set up by colleagues at Merseycare NHS Trust, where they've implemented a data visualization tool called the Management and Supervision Tool, or MAST, which draws data from patient record systems to help clinicians prioritize the care of people who may be at increased risk of a mental health crisis. So in response to the pandemic, an additional module was developed to flag individuals who were shielding or at increased risk from COVID-19. And we know that these individuals are at increased risk of isolation, which could be associated with worsening mental health. And identifying these individuals allowed clinicians to proactively offer interventions remotely to support this vulnerable group, and improved engagement in mental health services by almost a quarter between April and June 2020. So this example highlights how the data from electronic health records during the pandemic were analyzed in real time to provide actionable insights leading to improvements in patient care. So to summarize, COVID-19 has led to a substantial increase in remote mental health care, but with variation in rates of uptake between different patient groups. As a result of the pandemic, we now have access to an enormous repository of real-world electronic health data, which has been collected prospectively and documents the delivery of mental health care. So I think there's a real opportunity here to further analyze these data and generate evidence on the potential benefits and risks of remote mental health care and the best approaches to delivering it. And one way to do this could be to use a technique called natural language processing, or NLP. And this technique allows you to automatically extract clinically meaningful data from the free text of the electronic health record. And in mental health care, about 90% of the clinically meaningful information is in the free text. So I plan to use this approach to compare remote clinical interactions with in-person clinical interactions to better understand how remote care approaches during the pandemic could have affected mental health outcomes. And going forwards, EHR data visualization approaches could help to better manage limited resources and deliver more effective care. For example, highlighting which individuals may face barriers to accessing care and proactively providing them support to help them prevent deterioration in mental health, rather than the current approach, which is reactively managing problems after they've already occurred. So if you're interested, you're welcome to see more data from the study on an interactive dashboard you can get from this link here. And I'd like to end by thanking my colleagues who've supported this work and my funders, the Medical Research Council, HDR UK, and Academy of Medical Sciences. And if you'd like to read more, then I've also published the initial findings in the BMJ Open. You can get from this link, or just search on Google and you'll be able to find it. So thank you very much.
Dr. Patel, thank you very much. So we've heard from a whole health system, we've heard from a cancer perspective and from a mental health perspective, not only canaries in the mine, as it were, during the pandemic, but through to informing decision making. So let's turn now to questions. I'm very pleased to say that they've been coming in thick and fast. And the first one, which is actually a question to each of the three speakers, and I'll take it in turn in which you spoke, which is, which communities do you think are most impacted by the insights that you've developed? And to what extent have you engaged with these communities along the way? And in interest of time, I'm going to invite you to each consider just one community. So Richard first.
Can I just clarify what's meant by community?
I guess who's the end user?
Right, okay, yeah, sure.
What needle on what dial are you trying to shift, and who needs to be involved?
Got it, yeah. Yeah, no, that's really interesting, actually. I mean, as I started my slides with, one of the key things that I've been tasked with and my team's looking to do is really embed analytics. And one of the big challenges we've got is working in an environment where people are not familiar with analytics, and that includes clinicians, but also healthcare managers as well in the commissioning groups and in service delivery. So it's been really interesting. I think it's put us years ahead, frankly, in our system in terms of our efforts to try and get the analytics ingrained in those groups of people. I think.
I'm going to move on quickly because there are many more questions and I want to get through them. Mark.
Yeah, just inequalities. So inequalities were actually amplified by COVID and the pandemic. We found particularly actually in Central and Eastern Europe, we saw significant differences in relation to the impact of COVID. And we've been following that up with the patient advocacy groups in Central and Eastern Europe, and similarly in the UK and with some of our patient advocates. We found the same thing, that unfortunately the inequalities that are there already are amplified by COVID, and we really need to do something about that.
And Rashmi?
Well, I mean, as my data have shown, essentially vulnerable people with mental disorders who are often isolated. And I'm fortunate in my center, we have service user and care advisory groups. And I presented some of these data to them. And one piece of feedback which came back was about delivering remote mental health care, the importance of including patient choice in the approach that's taken for people. Maybe they would prefer in-person care or video rather than audio, and there are benefits and disadvantages. So I think that's a clear message that needs to come back to mental health services.
Okay, terrific. So we have a further question for you, Rashmi. So how much has electronic healthcare records usage changed? So how healthcare practitioners document disease, the language that's used, and the vocabulary that's used during the pandemic. Do you have any feel for that?
So I don't have any data on it, but I think, the main issues are isolation. I think also that there are people who have already had problems with their mental health well before the pandemic, and it's important to remember that hasn't changed. I think access to care is a big issue. So, I think these are some of the themes which are coming up.
Okay, thank you. Question for Richard. You gave some results about patients' responses to remote consultation. Do you have any insights on clinicians' views?
Yeah, not in a measurable sense, no. Only kind of more subjectively through having spoken to some clinicians, of which the feedback has actually been quite positive in some respects, of being able to work from home, not have certain inefficiencies in terms of travel and those associated with physical attendances. I guess maybe it's not totally clear in terms of clinical efficacy. I think there's certain specialties which are better suited to telehealth than others, but no, we haven't made an objective kind of survey or anything of clinicians' feedback.
Okay, so turning to the cancer work, so we have a question for Mark, which is, have you thought in your modelling how to take account of the, quotes, usually very sensible varying referral thresholds of GPs according to patients' needs and service pressures?
Yeah, no, I mean, we have looked at that and also looked at ways in which we can try and model that and look to see, using different, sort of levels, if you like, in relation to that. One of the things we'd like to do is also collect more of that data across the UK to actually see, are there variances, are there best practice that we can learn from? And we haven't really looked at that in the European context yet, but it is something that we've been talking about with the European GP Federation, for example. Just to go back to your previous point in relation to surveys, both of patients and also of health professionals, one of the things we found, the International Brain Tumor Alliance, for example, found that patients did highlight some issues that they didn't like in relation to remote consultation. So it's not all, sort of positive. And similarly, some, particularly European Society of Medical Oncology, one of the things doctors do worry about is that it's very hard on a video consultation to work out some of the nuances that you use normally as part of your normal practice when you're actually interviewing a patient, in terms of potential weight loss, in terms of just mood, etc., looking at eye-to-eye contact. So while it has obviously improved things and it has been adapted, it's not the panacea for all situations, and really the blended model needs to be looked at more, certainly in the oncology community anyway.
And would you have a view on the extent to which GPs' kind of wisdom and insights is kind of captured in the data that's recorded? Behind this question, I guess, is the idea that clinical judgment is being exerted, and is that captured?
Yeah, I think that's a really good point, and perhaps it's not being captured with the same nuances. The other thing is dentistry, for example, because dentistry shut down, and we know that dentists, one of the things they do is look to see, they do an oral cancer check, and that wasn't happening, and we're seeing that having an impact on, for example, head and neck cancer. So I think we're seeing right across the, the sort of pathway from GPs, dentists, etc., just things that we would have taken for granted have not been happening. And sometimes we're not thinking about that because we're just thinking about dentistry in the context of oral health, but not oral cancer, for example.
And staying with cancer, but I think it has a wider reach, this question, which is the other side. Is it possible before the pandemic we understood that in certain situations people were over-investigated, there may be over-diagnosis of certain things? Is that something that you've looked into? We focus very much on the indirect effects as negatives.
Yeah. One of the things we have been looking at is, for example, treatment breaks and continuous versus taking treatment holidays in relation to cancer, because we were doing that before the pandemic. We were looking at it particularly in the context of colorectal cancer, and we've continued to look at that. And there may be an example of actually where enforced treatment breaks may have been actually for certain populations, not for everybody, may actually have been relevant in that setting. And certainly there's some guidance now in relation to that. In relation to diagnosis, we haven't really looked at that, but it's a really good point in relation to diseases like prostate, for example, where there's potential for overdiagnosis.
Can I bring, thank you, can I bring Rashmi in here? So clearly if one is late in diagnosing treatment-sensitive cancers, that is associated with poor outcomes. It's a little different in mental health. Rashmi, have you had thoughts about what the consequences might be? I'm thinking partly about the crisis prediction work. The fewer that present in crisis, the better.
Yeah.
What are your thoughts?
Well, I mean, so the first thing is how long it takes, even before the pandemic. For someone with bipolar disorder, the time from first experiencing symptoms to being diagnosed could be over a decade. So, that's the first thing. There's an enormous delay, and we know that a long delay leads to worse clinical outcomes. And curiously enough, you were talking about, maybe the positive indirect effects. I think, in the space of a year, we've accelerated at least a decade in terms of the acceptability of remote methods for interaction with patients. And this could actually be a way in which we could reduce some of those delays and try and assess people a bit earlier and reduce some of those barriers to accessing care. As to what will happen as a result of the pandemic, it's far too early to say. I think in terms of what will happen, we'll have to wait 2 to 3 years with respect to the impact on mental disorders. But clearly, it's had a major impact on people's mental health, everyone. But what that impact will be in the long term, we don't know yet.
Harry, there's something related actually in one of my slides. I mentioned about some system-wide mental health flow modeling we'd been doing. And you can capture, as we did, the effect of basically, in queuing theory terms, it's reneging, so a patient joining a waiting list, and time-dependent reneging. So we captured that within our modelling to basically play in the effect of if a patient is waiting a huge amount of time because of the lower capacity, then there's a probability per day or whatever, an increasing probability that they will renege to a higher level service to reflect the escalating level of need of the patient.
Thank you. And that kind of segues nicely onto the next question, which is, it took a quote, this is from Matt Thakur, which took a quote from Mark's talk, we need to prioritise clearing the cancer backlog. What do we know about how the potential impact of cancer backlog compares to the potential impact of backlogs in other areas? And I'll ask Rashmi to go first here, because you said something quite profound, I think, that I don't think everybody appreciates, that many people with mental health problems have a diagnostic odyssey, and it takes years to diagnose, and early diagnosis may be associated with better outcomes. Demonstrated fact widely understood in cancer, but I think somewhat different in mental health. So it's about the timing and the backlog. Rashmi.
Yeah. So, I think this backlog is something which has always been there, and mental health services are overstretched. They were before the pandemic. I think, managing this will require an approach which takes the whole life course. And, we know in particular young people, school children, people at college, university, starting their first job, they've been disproportionately affected by the pandemic. I think, targeting services for children and young people will be very, very important to try and help support these people as we come out of the pandemic, and try and prevent some of the later impacts that could occur later on in life. Because sometimes there is a delay, the difficulties you experience when you're young could impact, decades down the line. So that would be, my thoughts around that.
Mark, lessons outside cancer?
Yeah, I mean, I think, the important thing is triaging and looking at ways in which we can triage. So if we do have capacity issues, are there ways in which we can be clever and use the data? We've got some examples now in cancer, which, some of them would be applicable. I think cardiovascular is another area where we've seen similar, and some of the work that Kathy Sudlow and their group have done in the cardiovascular data hub have shown similar issues in relation to cardiovascular as in cancer. I think, in a way, we've been fortunate that we've very much hit the ground running in cancer. So we've documented a lot of the challenges that we're facing. And I think it's really important not only use the data to highlight the problem, but also to use the data to help drive the solution. And certainly that's what we've been looking at in terms of, particularly in colorectal cancer and some other cancers. How can you use the data to solve problems as well as the data to highlight problems?
Thank you. I'd like to ask a question about the very large number of people with multiple coexisting conditions. So I'll start with Mark. How does this play out? It relates to the first question about who are the communities that we want to engage with here? Well, many, if not most people with cancer have other conditions which affect survival. And people who turn up in South London and Maudsley Trust have conditions which affect other organ systems apart from their mind. Mark, are there lessons that we can learn?
Really important. Just didn't have time to share that data. For example, we see comorbidities, COPD, diabetes, hypertension, cardiovascular, obesity. They came up when we actually looked at what were the comorbidities that actually even make things potentially worse. And obviously with some of those you can intervene. And so again, I think really capturing those comorbidities is critically important, because not only do they tell us what the challenges are and how it actually makes things worse, but also with some of those, if you can intervene, you can then actually reduce the risk. And so I would have said comorbidities, in fact, in general, we should be really looking together. And certainly we've been looking at with the cardiovascular data hub as to how we can work together to actually bring those data sets together. And that's why it's critically important that we collect that information as well.
And there's a new mental health data hub as well. I think we need to draw the session to a close. I would like to thank once again our three excellent speakers and all those who sent in questions. I think this has been a very stimulating discussion, and I hope it helps to prepare ourselves for, God forbid, third or subsequent waves. Thank you all very much indeed.
Thank you, everybody.
Thank you very much.